Well, first I'd like to thank the organizers for inviting me to this really interesting meeting. And I've been asked to talk about cancer vaccines and the basic science and concepts, as well as clinical results. So first I want to, as background, point out that for cancer vaccines, we really need a new vaccine paradigm. The classic vaccine paradigm to prevent virus infection, the kinds of vaccines we're all familiar with, is that acute virus infection results in viral clearance and long-lasting protection, and therefore a vaccine simply needs to mimic natural infection. But the exception is cancer and chronic viral infections, where an inadequate immunity induced by the disease allows the chronic infection or malignancy to persist. And in these cases, we must do better, or must induce better immunity than induced by the cancer or the natural infection. Cancer vaccines are distinct from most other vaccines. Vaccines against cancer can, as you've heard now from earlier speakers, can harness the exquisite specificity of the immune system to selectively target cancer cells and avoid the kinds of side effects that one sees with less specific types of therapy. To do so, we need to identify the molecules that are unique to or highly overexpressed in cancer cells to target with vaccines to distinguish them from normal cells. And you've heard a lot about this from the previous two speakers. Most vaccines are preventive vaccines, but cancer vaccines are primarily therapeutic to treat existing cancer. So that's a huge difference from vaccines that we're used to, although there is now a significant effort to develop prophylactic cancer vaccines. And long-standing cancers may have tolerized immune cells that could recognize them, and so we need to overcome this tolerance. And also, cancers exploit immunosuppressive mechanisms, some of which you've just heard about from Dr. Rizvi, to suppress the immune response against them. And we need to overcome this suppression. So I'll talk about all these issues as we go along. And I want to point out that cancer vaccines act fundamentally differently from all conventional forms of cancer therapy. So chemotherapy, radiation, surgery all target the cancer cell itself. But vaccines target the immune system of the host, and only secondarily the cancer cell that's targeted by the immune cell. And that is a fundamental difference that underlies a lot of principles we have to keep in mind. So vaccines require an intact immune system, unlike many other types of therapy. Now, there are two major arms of the immune system that most of you are familiar with. The antibody arm shown on the right and the T-cell arm shown on the left. And I just illustrate this, I show this basic slide to point out some basic differences between these. So antibodies can recognize on intact tumor cells only antigens that are expressed on the surface of the tumor cell, and that's limiting for cancer antigens, most of which are expressed inside the cell. So for example, HER2 is an oncogene product that's a driver oncogene that in a number of types of cancer that can be targeted with an antibody like trastuzumab, and we can make a vaccine to induce such antibodies, which I'll talk about. But most tumor antigens are expressed in the cell that can't be seen by antibodies. So how does the immune system deal with that? The immune system has developed an internal surveillance mechanism, a kind of spy within the cell called the major histocompatibility molecules, HLA in humans. And these molecules pick up peptide fragments that are made from every protein synthesized within the cell and carry them out to the cell surface where they display them to these CD8 cytotoxic T lymphocytes. And that allows the T-cell arm of the immune system to see what's going on inside the cell, where most of the tumor antigens are expressed. So most cancer vaccines have been designed to induce T-cell immunity of the types you've heard about, for example, for adoptive therapy from Dr. Rosenberg. But I want to give you an example of both. And so I'll start out with a cancer vaccine that induces antibodies against HER2. And so we made an adenovirus vaccine vector that expresses HER2 and in mice causes complete regression of large established breast cancers. Here you see this 2-centimeter fungating tumor, which is huge in a mouse. Within about 3 weeks, completely disappears in virtually 100% of the mice. We found out to our surprise that this was independent of effector CD4 or CD8 cells and completely dependent on induction of antibodies to HER2. But the mechanism was different from that of trastuzumab. It might work in trastuzumab failures. And based on that, we've opened a phase 1 clinical trial of a human version of this vaccine, which is showing early promising results, which I'll show you in a few minutes. But first, I want to show the ability of this to affect lung metastases because it makes a very important general point that I'd like to emphasize. And so what you see here are the lungs of a mouse that have been resected and injected with black ink 15 days after giving these breast cancer cells intravenously, and they form these lung metastases, so to speak, or nodules that you can see as these white macroscopic lesions within the lung. And if you let that go another 2 weeks, you see these are huge metastases throughout the lung, making it hard for the mice to survive much longer. Now, if on day 15, when you already have these macroscopic lung metastases, you vaccinate with 1 dose of this adenovirus HER2 vaccine, then 2 weeks later, there's no difference from the control unvaccinated animals. The tumors are growing, and even a week later, they're growing more. So if this were a patient, you would say the patient has progressed on therapy, the therapy has failed, we're going to take the patient off the clinical trial and stop the therapy. But for the case of immunotherapy, that would be a mistake, because if you let that patient mouse go another 2 weeks, virtually 100% of them are cured, all the metastases just melt away. So that illustrates the point that immunotherapy can take much longer than conventional chemotherapy, for example, to show an effect. And one cannot conclude that a patient has failed simply by seeing initial progression on therapy. So therefore, we need a different set of response criteria from the conventional RECIST criteria. And Dr. Wolchuk et al. A couple years ago developed what they call immune-related response criteria that take these considerations into account to use instead of conventional RECIST criteria for evaluating immunotherapy clinical trials. Now I'd like to show you some preliminary result just briefly of this clinical trial that we've been doing of a human version of this adenovirus HER2 vaccine. So this is one of the first patients on the 2nd dose level, a 63-year-old lady with gastroesophageal cancer, widely metastatic, failed all other therapies. And you see on the left a large index lesion. There are 2 lesions totaling 6.5 centimeters. And by week 16, that had regressed by 58%, and by week 24, not shown here, 70%. And in fact, in dose cohorts 2 and 3, 5 out of 10 patients so far, that is 50%, had clinical responses. 1 CR in ovarian cancer, 1 PR just shown, and 3 cases of stable disease lasting more than 6 months in patients with widely metastatic cancer who failed all other therapies that you would not expect to suddenly go dormant for more than 6 months without some intervention. So our plan is to extend this to breast cancer patients with amplified HER2 who failed HER2 therapies we haven't treated yet, and to increase the maximum dose, and the FDA has just approved both of those modifications. Now I'd like to turn to vaccines aimed at inducing cytotoxic T cells. So the first of these that was approved, in fact, I believe the only FDA-approved cancer vaccine is Provenge or Sepolusal T. And this is a pivotal trial in which you see that the median survival in the control group was 21.7 months, increased to 25.8, or a 4-month increase in overall survival, which led to licensure. But of course, we'd like to do better than that. That was in melanoma. No, sorry, in prostate cancer. I misspoke. It's a prostate cancer vaccine. And this is an example taken from the web of a Celldex vaccine against EGFR mutation in glioblastoma. And what I want to point out here is that even though there's not a huge shift in the median overall survival, only about 2 months, what you see is this long tail of about 25% of the patients that have long-term survival, which you wouldn't expect in glioblastoma. So that's another effect that we can see, and you saw that in Dr. Rosenberg's adoptive cell therapy studies and also in the anti-PD-1 studies that Dr. Rizvi just showed you. And that's an important thing to look for in immunotherapy that you might not expect to see otherwise. So we've tried to improve on cancer vaccines, as illustrated here. The basic skeleton of a vaccine is just an antigen used to induce an immune response, but we can optimize that in a number of ways. We can first improve the antigen itself by a process we call epitope enhancement, which I'll tell you about in a minute. We can then try to push and, more importantly, steer the response using defined molecular adjuvants, such as those listed here, to improve not only the quantity of the response, but more importantly, we found the quality of the response, the avidity, the longevity, and the type of immune function of those T cells. But that's not sufficient because, as you've heard, there are a host of negative regulators that cancers can exploit to block the immune response, both cells and molecules. I'll mention more specifically in a few minutes. And we need to overcome these to sort of take off the brakes so that when we give the vaccine, it can have its full effect and optimize the immune response. So I'll first talk about epitope enhancement because we've translated that to a clinical trial. And you heard earlier that antigenic peptides must be presented by an HLA molecule to the receptor of a T cell. So the peptide has some of its residues that interact with the HLA molecule and some that interact with the T cell receptor. And the concept of epitope enhancement is that if we can modify the residues that interact only with the HLA molecule to increase the affinity, then without affecting what the T cell receptor sees, then we can have a more potent vaccine antigen that will be more effective at stimulating an immune response, but will induce the same T cells because what the T cell sees is the same. And we've applied this to antigens from a number of viruses, including HIV and hepatitis C, and also to cancer antigens. And one of them in particular is TARP, which is a 58 amino acid prostate cancer antigen that was discovered by Ira Paston's lab that's expressed in about 95% of prostate cancer and about 50% of breast cancer. We mapped some epitopes presented by HLA-A2, which is the most common human class 1 HLA molecule, applied this epitope enhancement approach, and for one of the two epitopes that was more modest in affinity, we made one amino acid substitution, this 9V, which increased the affinity and immunogenicity, and were able to induce TARP-specific human T cells that would kill human tumor cells expressing TARP. And so we've tested this now in a clinical trial in stage D0 prostate cancer. And by stage D0, we mean that the primary tumor's been removed. There's no tumor you can measure by X-rays, but there's a rising PSA indicating biochemically that there's microscopic recurrence. And that's the only thing we can measure. And in that setting, the rate of change of PSA or PSA velocity has been shown to be a valid predictor of clinical outcome. So we've looked at the change in the slope of the PSA over time. And this waterfall plot just summarizes the results of this first in-human clinical trial at 24 weeks or at 48 weeks, looking at the change in slope from baseline pre-treatment. So for each of these is a different patient. A bar going down indicates a decreasing slope. And you can see that at 24 weeks, almost 72% of the patients, and at 48 weeks, fully 74% of the patients, or almost 3/4, had a decreasing slope, and that was highly statistically significant, would not be expected by chance alone. So we're highly encouraged by this, and based on that, we've now opened a randomized placebo-controlled phase 2 trial to try to validate this, and then hopefully move on to more advanced stages of prostate cancer and also to breast cancer. Now I'd like to turn to the issue of blocking negative regulation, because we think vaccines aren't really going to work without blocking such regulation. So the vaccine is trying to induce a CD8 T cell that can kill a cancer cell. But there are a host of mechanisms that can inhibit this. There are regulatory cells, such as all the ones listed here. There are regulatory molecules on the T cell itself that can interact with ligands on either the antigen-presenting cell or the cancer cell that can turn off that T cell, such as PD-1 and CTLA-4 that have been in the news a lot lately, and you just heard about from Dr. Rizvi. And then there are regulatory cytokines, such as TGF-beta, IL-10, and IL-13, that can inhibit these T cells. So the major checkpoint inhibitors that have been studied so far in the clinic have been PD-1 and CTLA-4. That's just this one class, but that's really only the tip of the iceberg for immune regulation. And we need to potentially block these regulatory cells and regulatory cytokines as well. And I'm just going to illustrate one example with blocking TGF-beta as another kind of checkpoint inhibitor. So in mice, using this colon cancer model, we're looking at overall survival in the mice. You can see the survival is very poor in the control groups and with the anti-TGF-beta alone. The vaccine in blue gives us only modest improvement in survival, but the combination in solid red gives 80% long-term survival, and that's completely dependent on CD8 T cells, because if we deplete them with anti-CD8 shown in the open red symbols, you see we completely lose the protection. So we can get strong synergy between this new kind of checkpoint inhibitor, anti-TGF-beta, and a vaccine, and similar types of combinations of vaccines and with anti-PD-1 or anti-CTLA-4 are under study as well. So we would like to translate that to the clinic as well. So now, I mentioned in the beginning, and you've heard from the previous speakers, that it's important to identify antigens that are unique to the tumor to target. And you've seen this slide already, so I don't want to spend a lot of time on it, but I want to point out that this is the frequency of somatic mutations on a log scale. So there's a 100-fold range here, or maybe more than a 100-fold range, between the types of cancer that have high somatic mutation frequency, like melanoma, lung cancer, and so forth, and ones that have very few mutations, like thyroid cancer, Ewing sarcoma, AML, and so forth. And some of these mutations are in sequences predicted to bind to the patient's HLA molecules, constituting what you've heard referred to now as neoantigens. And the previous speaker, Dr. Rizvi, showed this slide, and his group found that in patients treated with PD-1 blockade, the patients who showed durable clinical benefit had far more predicted neoantigens than the ones with no durable benefit, and had that is, the ones with a high neoantigen burden had much better progression-free survival. But one needn't do this extensive cancer genome sequencing to find unique mutations. So more than 25 years ago now, we and others realized that RAS is one of the mutations in RAS are among the most common mutations to current cancer, and these might be target tumor antigens. Without extensive tumor genome sequencing, we know that this is one common neoantigen, and it's a driver mutation. And we found that the common RAS codon 12 and 13 mutations, which are the most common, fall in a sequence that can be presented by HLA-A2, the most common human class 1 HLA molecule. And that's shown here. This region of RAS which contains these codon 12 and 13 mutations. I'm sorry, this is shifted a little bit, but anyway, fall within this region. And we did a study together with Dave Carbone and others looking at immunizing patients with peptides corresponding to their unique mutant RAS or P53 mutations. And among those who had a positive T-cell response measured by gamma interferon, had more than a year greater median overall survival than the ones who did not have such a T-cell response. So that's substantially more than the 4-month increase in survival that led to licensure of sipuleucel T, and is very encouraging. And this was started 25 years ago. This was published more than a decade ago, and it was a little too cumbersome at the time to do all the sequencing, but new rapid sequencing technology may allow revisiting this type of personalized therapy. Samir Khalif, back in the same era, had done a number of studies like this as well. And so there's ample evidence that mutant RAS can be a target neoantigen, and you heard an example of that from Steve Rosenberg. So now I'd like to finish with just 2 points quickly, and that is, one is about immunopharmacodynamics, to point out that this is fundamentally different from classical cancer pharmacodynamics, because classical PD, there's only one target cell, the tumor cell, and one has to look at the effect on the physiology of the tumor cell to define the mechanism of action of the drug. But as I mentioned in the beginning, vaccines don't target the cancer cell directly. They target immune cells, which then secondarily affect the cancer cell. So there are 2 target cells that one has to study in immunopharmacodynamics, and the interaction between these. And that makes the pharmacodynamics much more complicated to study mechanisms. This need for an intact immune system also leads to restrictions on preclinical studies and also clinical trials. Vaccines require an intact immune system. They cannot be tested in xenograft models in immunodeficient mice. Unlike most types of chemotherapy, they can be affected by prior lymphodepleting therapy, such as some types of chemotherapy. And MHC restriction requires HLA matching between T-cell specificity and target tissue. So one must use syngeneic mouse models. One can't use a tumor from one strain of mice in a mouse of a different strain. And finally, because cancer vaccines require an intact immune system, don't target cancer cells directly, have slower onset, and require immune-related response criteria instead of resist criteria, cancer vaccines must be viewed as quite distinct from virtually all the other cancer therapies to which we are accustomed. We can't just think of any immunotherapies really as just drugs off the shelf like any other anti-cancer drug. But we really have to take into account this important role of the immune system that may not apply in most other conventional therapies. Thank you very much.